Hello, everyone. Welcome to the next educational session of the USDTL ToxTime presentation. I'm thrilled to be your host, Madeline Tellerico. In today's ToxTime, we're honored to have Levi Stevenson and Guida Brown joining us. Together, they will delve into the compelling topic of Change Your Language, Change the World. Levi Stevenson is currently the Community Prevention and Education Specialist for Kenosha County's Division of Behavioral Health Services. He started in the field in 2002, working as an adult protective services worker, and has served in numerous roles since then, including court services unit supervisor, adult crisis unit manager, and crisis stabilization coordinator, and behavioral health quality improvement analyst. Having been trained by the Addiction Policy Forum in its anti-stigma initiative, Levi's current role finds him providing education to the community regarding stigma for behavioral health, while also working with local schools regarding early prevention and resources for services. Guida Brown of Guided by Guida has over 30 years of experience working in nonprofits, and more than 15 of those years were working with individuals with substance use disorders. Guida is a substance abuse counselor, FAS disorder trainer, and Intoxicated Driver Program Assessor certified by the state of Wisconsin, and she also serves as a member of the faculty at Concordia University, University of Wisconsin-Parkside, and Gateway Technical College. Please note that opinions presented in this session are those of the presenter and do not reflect any official policy or position of USDTL. All right, and with that, I will hand off the presentation to Levi and Guida.
Hopefully everybody can hear me and see my screen. You plan for the best, but you know. So yeah, 48 million people suffer from addiction, 1 in 6. That's a staggering number, and it's actually higher than that number as presented to you. And so we all, that number is an estimate, and that number is what's presented to clinicians and everybody else as far as they can diagnose. 50% of people in the US know someone who has suffered or currently suffering from substance use disorder. And again, that number is probably a little more accurate than the 48 million. 20 million Americans are in recovery. Recovery is a thing that can happen. There are services available, and we have to catch people and help them into that. 90% of Americans with a substance use disorder began using substances before the age of 18. I've been doing this work for a while, and it would amaze you to hear that the number of folks that have told me, oh no, I started using, or I started drinking, or I started whatever at 10 years old. That age staggers me a little bit, even though I'm a person who has lived in Texas, lived in New Orleans, lived in Wisconsin, who are some of the biggest alcohol use states in the US, but that age of 10 still gets me. Listen, I had my first beer when I was 10, but it was an accident. Like my friend's dad put his beer down, I thought it was my Coke, and so I grabbed it. It was a totally different thing than, oh no, I was using when I was 10 years old. And so that age, when I hear that from folks, and mind you, between me working with crisis and court services units, and what wasn't said is I've worked with our local treatment court program since its inception of 2008. And so that age just astounds me when I hear people say, well, you were using at 10 years old. That's just crazy to me. Research suggests genetic factors account for about half of a person's likelihood, and we'll get into that a little bit more in a little bit. So 48.7 million Americans had a diagnosable disease, substance use disorder in 2022. What I want everybody to glean from this slide is that first huge bar graph there. And that's the alcohol use disorder, right? And so we hear in the news a lot about opiates and things like that because they're killing people quicker. Alcohol use disorder has been the biggest disruptor of family systems not only in our area, but in the United States for a long time. It will, as far as folks being killed by it, it will take a longer time than some of the other substances, right? But is the biggest disruptor. There's more legal ramifications. It's on anything you want to ask. It's ongoing, ongoing, ongoing. In our area here, it's been on that level forever. You throw a stone in Kenosha County, you'll hit a bar, and it is what it is, right? And so when we talk about the substances being used, I want everybody to realize that while cocaine, cocaine's on the rise, back on the rise, I will say that opiates have been in the news. Alcohol is still the biggest disruptor. And so I want everybody to kind of keep that in the back of their minds or in the front of their minds. As Guida will always tell me, no, they need to keep that in the front of their minds. But we need to realize that that is the biggest disruptor of family systems.
Levi, I want to point out too that this 48.7 million, if you add up the bar graphs, the bar lines, it's over 48.7. So there's some substance addiction that we're not even paying attention to. And I could absolutely go off on a tangent, and I'm not going to derail Levi right now. It's obviously it's problematic, and the moniker of substance use disorder or addiction is troubling. Somebody had actually put in the chat that we're talking about specific to substances, right? Addiction is this whole other process problem that these numbers would be vastly greater. But the idea that even when we're trying to sort of silo the substances, that causes problems because we're not single substance users by and large. So sorry, go on.
Yeah, no, Guida, that is a great interruption, because if I, at times when I'm doing bigger presentations to our county board or other folks, I have time to get into that comorbidity or those co-occurring issues, and so there's also that to take in consideration, and so we always have to be wary of that when we're treating someone, is that they may or may not be using more than one substance, right? And oftentimes they are, and so we will get into that term of addiction a little bit, not a whole lot, but just when we get a little further in, because Guida and I had a great conversation about that, and we kind of agreed on it, because I'm like, that term of addiction is, but we'll get into that. So risk factors for developing an addiction, a lot of you know that. I don't want to get overly involved in this, but there's three main factors that contribute to the development of substance use disorder. Age of first use, I just talked about it. It's a big one. How can we stage that? Early prevention. Obviously, I don't know how many of you or where everybody is on this webinar, but if we can get more early prevention in the elementary schools, middle schools, high schools, that is one of the best things to do. Environmental factors, availability. Hey, we just talked about Kenosha a little bit. I don't want to downgrade us a little bit, but yeah, listen, a lot of places have the availability is there, right? Not only in the community, but in your household. How many of us have locks on our liquor cabinets, etc.? And so how can we get those early age and then availability things to lock into the same thing? And genetic factors. Does your family have a history of addiction, right? And when you know that, how do you stave that off as and try not to fall into it? And I like to tell the story, and I don't want to get into it too far, but hey, listen, I had an uncle who played in the NBA. That's one of my stories. And so this was the 80s. I'm not that old, but and so he got into cocaine. His NBA career ended. He died early. That's the shorter story of it. So how do you stave off those genetic factors if you know them ahead of time? And it's less like any disease, right? You want to do preventative measures. I don't care if it's substance use. I don't care if it's diabetes, heart disease. How do you stave off, if you know you have a genetic predisposition to something, how do you stave off those issues? Biopsychosocial response, factors that can contribute. And so we kind of are talking about this already. Biology, physical health, genetic vulnerabilities, drug effects, psychological coping skills, social skills, self-esteem, mental health, and social peers, family circumstances, and family relationships. So when you look at these three circles, you want to always pay attention to, as clinicians or as case managers, as whatever, how they intersect. And so, you know, if you have a genetic vulnerability to it, you don't have great family relationships or appropriate peers around you, and you don't have the coping skills, that's going to always interact and give you a higher chance of developing that substance use disorder. Addiction is a chronic health condition. I mean, look at the slides here. I don't need to overly complicate things or overly talk about it. Substance use disorder is diagnosable through the DSM. Everybody knows this at this point, and so we have to make sure that we as professionals are treating folks appropriately based off of that. And that's as simple as I can say it, right? They're diagnosed with a substance use disorder. Okay, how are we going to treat them? The key word is treat, right? There's multiple treatments out there. Obviously, you know, everybody's in a different area on this call. So you kind of have to know, okay, what's in our area to help this person get through that. And so, you know, I can't speak to everybody on what's where and what you have available, but we have to make sure that we, as professionals that are helping these folks, are aware of what's in our community to help everyone. So whether it's the drug addiction, substance use disorder, type 2 diabetes, hypertension, whatever you want to call it, whatever diagnosis they have, we have to make sure we're aware and can treat that person. Understanding and responding to people in distress, responding to people, which we'll get into in a few more slides here, is we have to have a lot of compassion and a lot of listening. I started in I'll say the human services business when I was 21 years old. I was so green, I had no idea what I was doing. You know, as all of us do when we start at that age, I had no idea what was going on. One of the best things one of my bosses ever told me, and her name was Janine, I'll leave that there. Levi, you got to be a good listener. You have to know how to listen to people. That just is. And if you can listen to people, then you have to understand that whether it's a client or an employee, if things aren't good at home, things aren't good anywhere. And so we have to kind of understand that when we're responding to folks, we have to be sensitive to what's going on in their life and be able to respond to it appropriately at that point. I'm going to let Guida talk a lot in the next few slides, but part of this slide was to kind of get our minds thinking, as some of us are clinicians, some of us are doctors, et cetera, of how our demographic biases affect how we treat folks. And whether it's, you know, you start with, okay, who's here? Oh, that's a Hispanic person coming into my office. Oh, how old are they? Are they male, female? How do they identify? Oh, wow, they have a substance use disorder? Oh, okay, I'm not. So we want to start getting rid of those demographic biases and things like that as we come across folks in our work life. So Guida, I'm gonna let you take it from there and let me know when you want me to switch slides there.
Yeah. All right, thanks. So one of the things, you know, we have often heard that there are professionals, with the sole exception of those people being in the substance use disorder field, there are professionals who will say, oh, I don't treat those people. And that is not an overstatement. Now, the idea that you don't treat those people is ridiculous, right? If it's 1 in 6, or even 1 in 6 for people who are in long-term recovery, to think that you're not treating those people is utterly ridiculous. But the bigger issue with that is, I've heard it in the mental health field. We have co-occurring disorders, and we don't treat them, but we treat the mental illness, we treat the mental health problem. And so we all have biases, right? We all have to recognize what our bias is before we can even think of addressing how we're serving other people. So next slide, please, Levi. So, okay, imagine, but actually before I move on, I want to thank Dr. Leslie Caldarelli from Lurie Children's Hospital. She helped me with sort of the idea of the layering. So if you like it, it's all her. If you don't like it, it's all me. So she gets no blame and all the credit. So again, if you want to use the chat, go ahead. You don't have to. This will come up later. You can raise your hand down the road. But the idea of, imagine your next person coming in, your next client, your next patient, whatever your field is, imagine that person has a substance use disorder. And so what does that person look like in your mind? If you understand the field of substance use disorders, you then know it could be anybody, right? But if you're new to the world of substance use disorders, or if you're not overly comfortable with it, or oftentimes we have sort of our donkey blinders on that, when I go to the doctor, I always feel like whatever body part that is ailing me is the only body part that goes to the doctor, right? So if my arm hurts, I go to the doctor and I'm like, the doctor's seriously only looking at my arm. And I think it's because that's sort of our approach, right? We go through life thinking I can't think of the word, where we just sort of stick to this is all I can look at in front of me today. And so if we don't consider that somebody might have a substance use disorder, we have a different picture of that. So what does that person look like when you know that that person has a substance use disorder? What does that person look like? How does that person present? And how do you feel about it when they walk in? So again, just think through your honest initial reactions to that. So next slide. Now consider that the client or patient coming in is currently under the influence of those mind-altering substances, as evidenced by the behavior. So a change, knowing somebody has a substance use disorder, is vastly different than somebody being under the influence of a substance, right? And there's an assumption, of course, that if somebody shows up at our professional establishment under the influence, it's because there's a bigger problem. It's not just something that happened last night and today they're still impaired. So why are they showing up with that substance use disorder? Then there's that substance use under their belt, substance use under the belt. And then now imagine that this is a middle-aged white woman, and to your knowledge, this person has never been seen before. Right? Does your picture of that person from the very first time I said this person has a substance use disorder, now is your image of this person different, right? Did you imagine this middle-aged white woman who's not, as we have been known to call them, a frequent flyer, right? All of a sudden, the picture is different. So next slide, please. Now, other issues that rise to the level. So age plays a factor. Rather than a middle-aged woman, it's a black 20-ish year old man who you've seen repeatedly. How does your opinion change? How does your reaction change? Or it's a pregnant Hispanic teenager currently under the influence of substances, right? That's what the scenario. or a 70-plus-year-old white man. We don't treat everybody the same. We just absolutely don't. And we shouldn't, right? That, I mean, this idea that we don't see certain things, we can't treat people that way. But when we recognize that our biases are getting in the way of how we do treat someone, if I can make a exception or an acceptance of a 70-year-old white man because I get to a story and his wife just died versus a pregnant Hispanic teenager, that's problematic. I mean, it's nice that I can understand what the man is going through, but I also have to be able to understand what the young female is going through in order to best serve that person. So, next slide. And then the presenting drug becomes problematic too, right? Presenting drug, somebody actually just put in the chat, I love it. Why is alcohol even still legal when it's so damaging? It's a really good question, right? We know that prohibition didn't work, and I contend that it didn't work because it was like trying to put the genie back in the bottle. It doesn't work because we already had the experience of it. I also contend that had we known how damaging alcohol was going to be, we would have legalized cannabis way before we legalized alcohol. Alcohol is much more damaging because of what happens to our brains. It absolutely turns off the good reasoning portion of our brains, and we make really bad decisions once we're under the influence of it. Now, and this is just my bias, and I don't work for the lab, it's the alcohol industry. That's why we're not going to ever make it illegal again. The alcohol industry is far too strong in our society. So again, the point being, when the presenting drug is known. So if somebody comes in under the influence and it's under the influence of alcohol, and we sort of expect, we know what to expect from somebody who's under the influence of alcohol. Or if they're under the influence of cocaine, if they're under the influence of opioids, or specifically intravenous heroin, right? That when we start thinking of the different levels of drugs and how drugs are even brought into the body, that changes how we feel about people. It absolutely does. And we know that. And that's how the bias that we have to get over. We can't treat people differently because we don't understand their drug of choice, or because we don't agree with their drug of choice, or even just, because. If they're unknown drugs, we have a lot of novel substances that people are willing to ingest all the time, randomly. And so what if we don't know? I mean, ketamine is said to be the PCP back in my day. It can be very, very dangerous. There are a lot of drugs out there that can be really off the wall. We don't know what the reaction is going to be. And so obviously we need to be cautious. We need to be careful, but we also need to treat people respectfully across the board. So I think you're back up, I think.
I am. I'm going to piggyback a little bit about this. And so I talked about my early career a little bit. And so as I was doing crisis work, and I'm going to put this back on me a little bit, because we had a shared client between crisis and the local emergency rooms who was constantly in the ER. Constantly. He really wasn't causing any problems. He just showed up in the ER. It just was what it was. But we had to have this big meeting about it. I'm like, oh, okay, why is he always in the ER? He's using up a lot of manpower, et cetera, et cetera. He wasn't really bothering anybody. He was just showing up in the ER, wanted some help. The ER sometimes will call us, sometimes they wouldn't. And so, but these are these biases. He's just a middle-aged white male who is a long-term alcoholism. And so why did we have to have this big meeting between crisis, the hospital, and the police department about this person who wasn't causing any problems, really? And so these are these biases we had that, and so when I talk about these things, as long as I've been working, I've had to get some of these things out of my own head, right? And some of these languages, and we are all educated in a certain way, if you've been in this business for long enough. And so we all have to correct certain things. So we're going to correct, what we're trying to correct is some of the stigmatizing language. So substance abuse, right? DSM, it's substance use disorder, right? We don't say substance abuse, it's a substance use disorder. Obviously your substance may be different, but it's a substance use disorder. That's one of the things we want to get rid of. It's not substance abuse, substance use disorder. Addict and junkie. Hopefully none of you use this, but if we want to get rid of that, it's an individual diagnosed with substance use disorder. I want to kind of stop here and kind of talk about, there's nothing wrong with the word addiction. All right. We don't want to use the word addict to describe someone, but there's nothing wrong with the word addiction in itself. It describes something else, right? I can have an addiction to food, right? And so that's how it's going to describe it. I have an addiction. What is it? Do you have an addiction to food? No. What is your addiction? It might be a substance use disorder. Okay, what is it? Alcohol. Okay. So there's nothing wrong with the word addiction. It's hard because folks can't separate the word addict from addiction, but they're two different terms. And so if I'm not a person in recovery, so I'm gonna put that out there. I've worked with many of them throughout the years. They will self-describe as an addict or a junkie. I will never call them that. Not once will that ever come out of my mouth. And so they can self-describe as an addict or a junkie as they want. They are in recovery. I am not going to call them that, but they will use those terms. Addiction, there's nothing wrong with that word. Guida, I see you unmuted.
Yeah, so the addict junkie language. So people, when they're in the rooms, they will absolutely use that language. And so when they're used to being in the rooms, they come out of the rooms and they use that language elsewhere. And that is confusing to people who don't understand why they're using that language. And so I would impress upon people who are in recovery that they should try to stay away from using that language if they're not talking to other people in the rooms, and because it's confusing when we hear that, well, he calls himself a junkie. I know, but that we just, that's not an appropriate word, and it's not an appropriate word in a professional situation, or an addict in a professional situation. So go on.
Thank you, Guida. Yeah, and that's exactly what it should be. If we're professionals, we should never use those terms. Clean. All right, that's kind of a probation term, or you want to say it. So we don't use that. I was like, I don't use that. I'm not a probation officer. So it's a negative UA. It's a negative drug test, or you're in recovery. So however you want to phrase it that way, you're not clean. You're not doing laundry. There's nothing going on there as far as that goes. Like, so negative UA, negative drug test, or you're in recovery. Dirty, again, you're not doing laundry. So it's positive UA, a positive drug test, and we'll leave it at that. I know, listen, I 25 years I've used these terms. I get it, but we got to get rid of that. And I am so careful now when I hear things and I'm like, wait a second, what did they say? Or what did I say? Let me rephrase that. And so I caution everybody to do the same for themselves, just to be like, okay, let me be careful about what I'm saying here.
About how demeaning this is, because it's just demeaning language, right? He has a dirty test, but we rarely even use that language. We say things like, he was dirty, which, oh my gosh, are you serious? And so I will say, having worked with the lab, we really learned how to come out of this. The other problem with it is when we say it's a negative test, negative in our minds is bad. And so when it's a negative test, that's a positive thing, but you really have to learn that language. It is so demeaning to say that somebody is dirty or clean. And again, and don't come back to me and say, oh, I didn't say he was, I said the test was. No, the test is positive or negative.
Right. I'm gonna go right back to Guida right now. And so what we're talking about these terms, and then us as professionals, we're gonna say, we hear somebody else saying that. Well, it's like, well, wait a second. What did you just say? So how do we help others professionally in the community say and use the right terminology? And how do we politely correct them or suggest they use a different term? And so some of these things, go ahead, Guida.
Yeah, so somebody asked in the chat, or in the Q&A, do I correct people who say I'm a junkie? I absolutely do. I'm not in the rooms, and so in my spaces, that is not appropriate language. I would also correct a person who has a physical disability and says, oh, I'm a loser, whatever. I would say, what? No, you can't walk. That has nothing to do with that. So I absolutely correct people. And when people say something inappropriate, I say it to strangers, honestly. I mean, if somebody says, oh, he's a drunk, I say, oh, we don't say that. We say he's a person with an alcohol use disorder. Like, I will literally say it to strangers. And I have zero qualms about that, because to me, it's just being respectful to people in general.
Yeah, and I think if you have other professionals in the room that you're sitting with and you appropriately correct their terminology and they can't handle that, then they're probably in the wrong business to begin with. So when we say, oh, they're not an addict, they're a person diagnosed with a substance use disorder, they should be able to accept that and change their language in that sense. Obviously, when we're talking about community members, it gets to be a little more sticky, like we just said. But we definitely should correct their language, because that's where it starts. Right? We want to start with the community as a whole. That's what prevention is about. And you start prevention in the community. And so you want to make sure you're correcting everyone. I want to get to the Q&A as quick as we can so folks can have a chance to ask questions. The myth of waiting to rock bottom, or for rock bottom, I really don't know where that ever came from. But that's just my so you want to catch folks as early as you can to get them into treatments. And so, and that doesn't mean they're always going to be accepting, but they don't have to wait till they get arrested to start treatment. I think that's been a whole community thing, and I use that arrested thing as just a general. They don't have to wait till they get arrested. They don't have to wait till they get divorced. They don't have to wait till whatever issue they have to get treatment. The earlier you can intervene, us as clinicians, us as community, that's the best thing. There's no, oh, we got to wait till they hit rock bottom. There's no such thing. You want to intervene and go from there.
And if they do wait, it's just as successful. So to say that somebody can't be compelled to go to treatment, or that they don't get better when they're compelled to go to treatment, is inaccurate. The recovery rate for any chronic disease is the same. And so asthma, diabetes, they're the same. People have periods where they return to being sick at the same ratio that they do for addiction. And oftentimes, he went to treatment because he got arrested, or he went to treatment because his wife threatened a divorce. Most people don't go to treatment because they just wake up one day and say, I think I need treatment today, right? Most people are really compelled in some way, and it is just as successful.
Yes, of course. Obviously, I work with treatment care programs, so we compel people to go to treatment all the time. I use that in quotes, but obviously, sometimes it takes a while, but doesn't matter how they get there, as long as they get there, right? That's the whole point. When we talk about prevention, kind of like I talked about, we want to make sure there's no missed opportunities. So that early intervention and prevention starts with family systems, right? Oh, okay, we intervened with this through Child Protective Services when this person was 8 years old, and now we're still working with them when they're 21. What did we do when they were 8 to kind of help that person? Education systems, obviously. I don't know if we have school district folks on the call or people that work in the school systems, but you know, anything we can do to educate and help our children and our, you know, at that in that school age kids, like we absolutely have to stop and educate and or intervene when we notice something like that. Healthcare, big one. I mean, I don't know how many clients I've worked with, and I call them clients in my previous realm, that well, I've been in my doctor all these times and they've never said anything to me. What? Huh? Like what is happening? Like I don't understand that. And so, you know, it's just not about saying, oh, you need to do this. We have to have a plan, which I'll get to in a second. Faith organizations. This is a big one, right? How many folks that are involved in their church and how many pastors, a lot of times a parishioner will go to that pastor or priest first to try to get help, and they don't know how to help them. And so it's about some of that prevention and outreach to those faith organizations to let them know what help is out there for their folks and their parishioners. And then employers, right? I mean, us professionals, we all have our EAPs and our employee assistance programs, but what are we really doing in the workplace to help our folks? I mean, any of us that have a bigger employer and where there's hundreds, there's plenty of folks that they're going to have a substance use disorder. How are we helping those folks and getting them into assistance early? And it's all about starting conversation, right? And where is that? Are they low risk, risky use, and you know, or are they a full-on substance use disorder? And that's hard to sometimes see as an employer or as somebody in the community, right? But as a clinician, you should be able to delve into that and figure that out and diagnose. And so part of that is just talking to them. I know that's hard, right? How do you talk to somebody with substance use disorder? I mean, that sounds weird. That's going to be uncomfortable for me. It shouldn't be uncomfortable for me because I'm not the person that has a substance use disorder. As a clinician or as a doctor, that's just a thing you should be asking them. If that person has diabetes or a heart disease, how are you raising that subject with them? It should be the same exact conversation, except the treatment's going to be a little different, as oftentimes it is, right? Unless you're dealing with different modalities at that point. But you raise the subject. Okay, I noticed you're in your paperwork, you're drinking a fifth of vodka every day. Okay, how does that make you feel? Okay, as a doctor, I think you're drinking too much, et cetera, et cetera, et cetera. And this is going to affect your health by A, B, C, and D. The hard part for a lot of our clinicians and our doctors is that then they don't know where to go. And so depending on where you are in your community, you have to make sure you know what services are available in your community. And I know sometimes that's on your our behavioral health division doing outreach or et cetera, but you have to know where to go to get that person help. Guida, go ahead.
Well, and also what medications are available. A lot of doctors can prescribe, nurse practitioners can prescribe, and there are medications that don't need any other
licensing.
Yeah. So
and that's a whole different presentation for me. And so obviously there are many medication assisted treatments. If it's an opiate use medication for opiate use disorder, whatever you want to use. I mean, Suboxone, buprenorphine, you can use all the brand names if you want. And so you have to be able to see where that person is and what they're willing to do. I will say, and this is just me, none of that helps if that person's not in therapy or doing something long term. And anybody else who says otherwise, I don't know. But there's always a root problem. If you start this medication, there should be something else going along with that. And that's whether it's naltrexone, which is the Vivitrol, buprenorphine, methadone, what have you. There should always be some other treatment to go along with that medication-assisted treatment for their substance use disorder. I'm going to end on that part and get to the Q&A if there is any. Thank you.
Subscribe to our channel and visit our website for more information.